Good evening, everyone. If you're following our previous discussions, we are discussing about cancers related to urological system. I am Dr. Ashwin Tamhankar. I am a consultant Uro-Oncologist and Robotic surgeon at Apollo Hospital, Navi, Mumbai. So today's topic would be pertaining to kidney cancers. Last time we discussed prostate cancer already. We are more than happy to answer any queries submitted to us on this channel. So coming back to the kidney cancers, if we actually see the data from the globe, it amounts to about 3% of the cancers in the world. Male to female ratio is around 1.5:1. However, the incidence or the male to female ratio in Indian context is nearly 4:1. So it is slightly higher in Indian context. The average age of incident occurrence is nearly within the range of 60 to 70 years, approximately 64 years. Again, comparing that to Indian standards, it is 55. That means Indian situation nearly we get kidney cancers 10 years or a decade earlier than the global literature. In last one entire year, the incidence is slowly creeping up, but that is happening majority in developed countries. In developing countries, the rate of increase isn't too high. But if we actually see the projections, the incidence is going to come down for developed countries, and for countries which have low socio-demographic index, in which India actually fits into picture, until 2030, the incidence is going to slowly increase further. The mortality because of the kidney cancers or the death because of the kidney cancers, Asia amounts to about nearly 45% of the total bulk, which is a significant and harsh reality. And obviously, India is a major contributing country in that particular percentage. So again, to reiterate about factors in Indian context, we are one decade earlier. So average age of incidence in India is nearly 55 years. Male to female ratio is about 4:1. We have higher proportions of men coming with this cancer. Probably the reason being females do not generally come forward with the symptoms, or they don't attain their regular health checkups, and that's why the incidence is slightly less in females. Not that they have some genetic protection, but that is just because of the way it behaves or way it is presented to the doctor. Another important fact in Indian context is cancers or tumors less than 4 centimeter, which are very small in size. Ideally speaking, they amount to only 10% of the entire cancer cohort detected for kidney cancer. If you compare this with Western literature, nearly 60% of the kidney cancers in West are detected in a very small stage of less than 4 centimeters. But that is only the percentage of that, comparable percentage of that is only 10% with Indian standards. That means we are getting more cancers with higher size or greater size when the options are unfortunately limited. So etiology wise, or what are the factors which are associated with kidney cancer? There are only three important proven factors so far. First and most important is smoking. Obviously, smoking is not good for any in general for body health, or it has implications with many cancers. Coming to uro-oncology or discussing about uro-oncology, bladder cancer is the most common cancer happening because of smoking, and then kidney cancer is second most common cancer in the uro-oncological spectrum. So generally, smoking has a long-term association, and it is equated with the pack years which someone is consuming the cigarettes for. So beyond 20 pack years, the risk escalates many times. And whenever suppose someone actually stops or holds smoking or refrains from smoking, the amount or the risk for that particular individual to be normalized would take about 10 to 20 years. So it's not going to happen overnight, and that's why it's always better to stop smoking as early as possible. Second important factor is obesity. It has certain implications, not to a very massive extent, but has some implications. And likewise, hypertension is another third most important factor, which gives rise to increase in the risk of kidney cancers. And if you notice all these three factors, smoking, obesity, and hypertension, these are all modifiable risk factors. By which I mean they are not present in a particular individual because of virtue of genetic associations or because of birth. So these factors are in your own control, and you can only reduce or cut down on these risk factors to reduce the risk of kidney cancer per se. Pathology, coming to the pathology of a kidney cancer, pathology wise, there are 4 or 5 types of kidney cancers. depending upon the percentage, clear cell or papillary. These are the most common variants out of it. I'm not going in details of it, not to have too much of technicality, but there are some syndromic associations or familial cancers which have kidney cancer as one of the presentations. So these are multi-organ involvements in syndromic cases, and they have different other systems which are getting affected because of familial association, and there are about 8 to 9 familial syndromes which have been described for kidney cancer. I'll be discussing a brief about management of these particular cancers. So before managing any case, first and foremost is to do an imaging for a particular patient to understand that the cancer is actually localized in the kidney, or unfortunately it is gone beyond the kidney, for which we need to do a CT scan, and along with that we need to do a CT scan of the chest. So just to reiterate the facts which we had discussed previously in the prostate cancer webinar as well, that whenever the cancer cells are in the particular organ, the intention of treatment is cure. But whenever the cancer cells actually go beyond the level of organs through the bloodstream to different body parts, where it is called a stage 4 cancer or a metastasis, then the intention of treatment unfortunately is not cure but control. The same implies for kidney cancer. So first and foremost is to have an imaging of a patient to rule out a metastasis and prove that the cancer is only localized to the kidney. So quickly about the biopsy, there is a little discussion which every time happens on the biopsy. The cancer biology of every individual organ is different. That's why for prostate cancer, if you compare, biopsy is a must in any stage. However, in kidney cancers, if you actually go into details, whenever a patient is fit for surgery or fit for any intervention, then biopsy is generally not recommended. So biopsy would be done for only those candidates who are very old to tolerate any treatment, or those who have been diagnosed in a state where there are metastases and there is no reason for us to treat the particular localized organ or a kidney. So in a fit individual who is presenting with a mass in the kidney based upon the imaging findings, we have enough evidence on the CT scan to correlate that with likely pathology of that particular lesion. In that case, we generally avoid biopsies for kidney cancers. So coming to the management, kidney cancer in a way is a surgical disease. Radiation or medical chemotherapy doesn't act much. Chemotherapy is reserved in only metastatic settings where the cancer cells have gone out of the kidney to different body parts. So surgery wise, by and large, it's like I said, it's a surgical cancer or a surgical mass. Whenever we are getting a patient in an early stage when the cancer cells are forming a conglomerate which is probably of a size less than 4 to 7 centimeters, then we have an opportunity to take the only mass out and spare the rest of the kidney on that particular side, which is called as partial nephrectomy, also called as nephron sparing surgery. If I can tell you the meaning of it, nephron is a functional unit of a kidney which produces urine, which filters body fluids. Hence, and it is very important for us to have as much nephrons as possible. So in a setting when a mass is of a relatively smallish size, the aim is always to preserve the nephrons and simultaneously achieve cancer control by taking out that particular mass only. Hence, whenever it is detected in an early stage, the chance of sparing that particular kidney or partial nephrectomy is possible until a size of 4 to 7 centimeters. Beyond that, generally partial nephrectomy is not a very possible option except for certain exceptional cases. So coming to the approach for partial nephrectomy, it can be done either in a conventional open manner, or in last few years or last few decades, it has been converted to minimal invasive approach in which laparoscopy and robotic surgery stands a chance. The quick differences between two: open would have a big scar on the tummy. It goes through the rib cage. One of the rib needs to be resected, and hence the post-operative pain. However, minimal invasive is the surgery is done through small keyholes, and patient is relatively pain-free. The overall precision with the robot, coming to the robotic part, the precision with the robotic surgery is absolutely impeccable. The blood loss is hardly anything. Patient doesn't require blood transfusions. There is a magnification in the vision. There are 7 degrees of freedom which a robot allows us to have good maneuverability inside the tummy of the patient, and it has a three-dimensional vision. So it seems like we are actually sitting in the tummy of a patient and operating or taking the mass out. The coming to the stage or the size where partial nephrectomy is not feasible, that means the size of the tumor in which it is detected is largish. Again, that it is called as a radical nephrectomy. Radical nephrectomy, again, the intention is to take the whole kidney out so as not to leave any cancer cell behind, and depending upon the pathology report, patient would be followed up. Radical nephrectomy again can be done either in an open conventional surgery or laparoscopic or a robotic approach, depending upon the pros and cons of each individual approach, and it has to be an individualistic decision after discussing with the patient about the entire process, and patient has to understand about all the modalities and options which he or she has. I would quickly tell you about the follow protocols. Generally, it's a cancer operation, so it's not that patient would get the surgery done and that would be the end of the story. We need to follow up the patient on regular intervals to ensure that the cancer cells are not coming behind. That is one perspective, that is called as oncological follow-up. And simultaneously, like I said, kidney is a functioning unit. Whenever we are taking a part of a kidney on one particular side or the entire kidney on the other side, we have to ensure that the opposite kidney is functioning well, and in which there is a role of a nephrologist who can look after the patient very well in terms of preservation of the renal functions or renal units or nephrons functions in long run, so as to avoid any long-term complications like dialysis, etc. So just to reiterate the whole thing which we discussed in few lines, kidney cancer is a surgical disease. Earlier the detection or smaller is the size of the kidney mass during the initial detection, better it is in terms of outcomes, because we have an opportunity to only take out that particular lesion, sparing the same side of the kidney and obviously sparing the other kidney as well. The main motto, there is no screening evaluation. Like if you compare or if you have gone through my previous talks, prostate cancer has a screening in terms of serum PSA levels. Kidney cancer will not have a direct screening evaluation, but as a part of routine health checkups, whenever the ultrasound is done on say once a year basis or once in a couple of year basis, it generally detects masses of size 2 to 3 centimeters, and that would be the time when that particular individual has to approach a doctor for evaluation, for getting a CT scan done, and then management thereafter. So whenever you have any mass detected in the kidney, do not hesitate to come forward. Bleeding in urine is a late manifestation of a kidney cancer. Obviously, any blood in the urine cannot be neglected. It can be either because of the kidney cancer or the bladder cancer, but not every individual with kidney mass would have bleeding in the urine. That's why be vigilant, come forward for the treatment. Obviously, the pandemic is nearly getting on a diminishing scale in India, but in spite of whichever stage the pandemic is in, we cannot leave a cancer cell in the body behind. So try and come forward. We are here to help you out at Apollo Hospitals, and we have it's a JCI accredited hospital, and we have all the possible technologies and management under one roof. Thank you.